Let's talk about Chapter 16, Quality Improvement and Risk Management. This is a huge piece of healthcare in today's time, and it will be forever. I even think they were doing quality improvement and risk management 200 years ago. It just wasn't called that. So the chapter starts out with the normal outline, objectives. Look, there's only two key terms for this chapter. There's a case study mentioned there that's not relevant to your quizzes or tests. Page 346, the introduction. Quality improvement is a process of looking for ways to improve the patient experience. We want to make sure we don't do any harm. That is actually a oath that we take as nurses and doctors. I think maybe physical therapists and dental hygienists take one too. I can't remember. The point is to do no harm. And so the quality improvement feature or process in healthcare is extremely important. Risk management is part of that, making sure that we stay safe as employees and that our patients and family members stay safe also while visiting the healthcare field as patients or visitors. 346 goes into creating a quality improvement program. This is so diverse in real life, depending on what office you work in. It could be huge if you're in a complex that serves multiple um, disciplines of healthcare, or if your office is a teeny tiny little 30 by 50 space inside of a like an outdoor mall. That's not what I'm trying to say. Strip mall, is that what I'm trying to say? Like where somebody pulls in and out. Anyway, your space is not that large. Your quality improvement program may be a little bit smaller, but you'll read all about that in this chapter. Page 348 speaks to avoiding patient injury. I just mentioned that. Developing trusting relationships with your patients, you can get far. Even if something goes wrong, you can mitigate issues as long as no significant harm was done. You can make someone happy or satisfied based on the relationship that you build with your patients. Starting at the front desk, who greets your patients when they walk in? How is their attitude? What is their presence like? Are they nice? Are they ill acting like they're not happy to be there? All of that makes a difference. And I could compare so many doctor office experiences, medical office experiences, versus the customer service you get at most Chick-fil-A's versus the customer service one may receive at other fast food restaurants. So anyway, but developing that trusting relationship with your patients and good, great, excellent customer service is really key to having excellent outcomes and good results with patients, even if something doesn't go quite right. Okay, so page 349, reporting tests. This is when a medical office member receives a test result. How quickly you report it is very important. We want to limit the time, especially if it is a bad report or not, if it's cancerous or if the blood work is really not normal. We need to let people know that immediately. Page 350 goes into communicating, and not only those like lab results or test results, but possible outcomes. Whenever you're in a medical office building or a practice that does procedures, you have to, part of the informed consent, whether it is as simple as uh, something, a laser or a mole removal, or maybe you do some in office surgeries that are a little bit more detailed, or maybe it's just as simple as um, I can think of 100 different things to say. A simple office visit versus a complex office visit. Your patient has to be informed. They have to give informed consent when they're signing documents. The person who is responsible for making sure the patient is informed completely, that it goes for the physician, that goes for medical office staff. It's very important that, excuse me, outcomes have been communicated with the patient. I think ultimately it would be a physician's responsibility, but most often you're either going to have a medical assistant or a nurse with the patient the most. So it is a team effort. Communicating with other team members. This is essential in a medical office to minimize risk and improve our quality for our patients. If you are working with a quiet coworker who is afraid to speak up, we're going to have to work on that. They're going to have to do some self-improvement there of their own, because you don't want that person to notice a mistake or make a mistake or need to report something and they don't have that ability to communicate well. So yeah. Page 350, what does that say? Two, recognizing limitations within your scope. All of our scopes, nurses, medical assistants, dental hygienists, physician assistant, nurse practitioners, the state dictates our scope. As a nurse in North Carolina, my scope is um, limited compared to nurses out in California, Arizona, Utah. Nurses can do different things in states out west. Most of the times in our state boards of nursing here on the East Coast, like for example, I'm not supposed to intubate a patient. I have to be trained how to do it, but I'm not supposed to do it. It's not within my scope. Interesting there, right? Page 352 keeps going, documentation or documenting non-compliance. How do you document non-compliance? How do we handle an accident or a most accident? Or not negligence, but medication errors. That's the very next paragraph. That's what I was going to say. A near miss or something that almost happened. It needs to be reported. That way, risk management can ensure that it doesn't happen with a new quality improvement plan. Page 354, reporting, oh, look, near misses, good catches. And this is something that's actually applicable to today's time. There's the hospital I work for, we have a program that you can go online anonymously and say, hey, this just happened, and I think, we could do this or this to fix that. And people, it's an entire risk management team job to review those and follow through and follow up with managers and just talk about it the next meeting. Page 354, communicating after an adverse outcome. You do want to have a debriefing if there is ever something that goes wrong, whether it's a sentinel event um, or wrong site, wrong side. If you're doing surgeries, you do want to have that meeting with your staff. Service recovery, page 355. So this is a way that you can help keep patients happy if their needs are not met, or if they had a inappropriate, not inappropriate, what's the word I'm looking for, unmet expectation. That's if they had a an accurate expectation of what their office visit was going to be like, whether it's their fault, your staff's fault. You do want to have a service recovery option to keep I'm not saying you have to make everybody happy. That is impossible, but you do want to be able to offer fixes if something does not go right. And I suggest looking things up, simply Googling different service recovery ideas for medical office managers. Page 356, incident reporting. Page 357, decreasing the likelihood of mistakes. This chapter does a great job at talking about that. Personal accountability. We do want to own our own mistakes. It is okay to say, hey, this is what happened. This is what I did. And it can be anonymously, certain institutions, and sometimes you have to own your mistakes. And yeah, I won't there I was going to say something about a legal case last year, or was it 2 years ago, but I'm not going to go there because I'm already 8 minutes in this. Most of the time, majority of the time, a healthcare person owning their own mistakes does not result in losing their job, especially if it's the first time, second time. Now, if somebody has a policy in their medical office that three mistakes, like three strikes, you're out, then that it is what it is. But in healthcare, we really do want that open communication with, hey, this doesn't work, this almost happened, or this, it did happen, and luckily, there was no side effects, but we need to prevent it from happening next time. There's usually that open line of communication. Page 358, use of protective equipment. This gets into some of the OSHA information we've covered, but the hospital or medical office that you work for, it's their responsibility to provide you protective and personal equipment to wear. PPE is what we call it. During COVID, all the hospitals, all the offices had to provide it for their employees. There were plenty of stories where Nurses were rinsing and washing their N95 masks because there were not enough to go around, which is terribly sad. But that the hospital or the medical office is responsible for providing that. Hazardous waste disposal. I'll let you read all about that. Oh, that's it. Oh, employee safety, page 360. And then there's the chapter summary. Getting close to the end. Please let me know if you have any questions about chapter 16.